All right, we have a few patient scenarios which should be fun. These are focusing on endometrial and cervical cancer. So our first case is a 58-year-old obese woman. Her BMI is large, but not very, very large, with grade 2 endometrial cancer on endometrial biopsy. She's otherwise very fit and active, has no other known medical problems. So in deciding the next management step for her, so postmenopausal woman with grade 2 endometrial cancer on biopsy, how many people generally would take this patient for an open laparoscopy? Grade 2. 58-year-old grade 2, BMI 48. How about vaginal history? You do it open, yeah. How about vaginal hysterectomy? No. Laparoscopic? Robotic? Anyone have any other approach that they favor in this patient? What's that? Yeah, well, and what approach would you generally favor to lymph node assessment? How many people would do a pelvic lymphadenectomy only? Okay. How about pelvic and aortic lymphadenectomy? How many people would do a sentinel lymph node assessment? How many people don't assess lymph nodes in grade 2 cancers? Interesting. Any reason why sentinel lymph node assessment is not kind of something that's... Have people experimented with that, or was it, kind of what we were talking about today, was that relatively familiar to everybody, the sentinel lymph node data? It kind of has become very popular in the United States all of a sudden. For a while, I think there were more detractors than there were proponents. There were a couple centers that really pushed it. And then almost like, in the course of a year, a whole mess of people have kind of switched over to doing it. And not really because there's a whole lot of new data showing that it's beneficial so much as people kind of discovered that they could do it. So... No, so let's, I guess for ease of discussion, let's say that we're going to do it with the robotic platform, because most of the robotic cameras have a near infrared feature built into them where you can pick up this ICG dye. So, the kind of before the case starts, I'll go to the little OR pharmacy, I'll get the ICG powder, we'll mix it in 20 cc's of water, and we'll draw up 4 milliliters. We'll inject, once the patient's asleep, we'll inject 2 milliliters each side of the cervix, so at 3 o'clock and 9 o'clock. And then you reliably have about 20 to 45 minutes that you're going to get good resolution of that dye. So some people had advocated placing all your ports and then injecting. You probably need a little bit more time, so I generally inject before we put the ports in. And I wouldn't say that I do sentinel lymph nodes as a standard procedure, but I've done enough of them to kind of have the procedure down. And then kind of you expose the lymph nodes the way that you normally would. There's a switch on the camera where you can switch it from near infrared to normal, and when you switch it to near infrared, the screen goes gray, and the tissue goes to like a grayscale. And anything that lights up with the ICGs is a bright green. So it's very easy to identify, whether even transperineally identify where these channels are. And I think that's part of the reason for its popularity, is that it's so easy to do. Now, it doesn't identify all you're doing is identifying the lymphatic channels. It's not identifying any areas where there's tumor. And I do think there's a fair amount of frequently, there's more than one sentinel lymph node that you identify on each side. I think the pitfalls of sentinel lymph node assessment include not waiting long enough to see whether you have an aortic sentinel node as well, since we do know that there are plenty of patients that skip, and kind of what do you do if you're not able to accurately map sentinel nodes on that side. Most people don't advocate sending sentinel nodes for frozen section, because the... Correct. Correct. Yep. And then you base your adjuvant treatment based on what the results are that you have. Yep. And the only time you do a lymphadenectomy is if you're not able to map that side. And then, yeah. Yeah. Uh-huh. What we found, for example, is you can identify the system, but when we do the assessment, we find really large, which is quite suspicious. Most of it actually come back and be sent for frozen as reactive. But once, for example, you identify the system, but you can find around a few large, you will still go ahead and do it. This is the problem with phase that we can actually, even after doing the injection, yeah. Once you start to see some of the organ, the body, you have to go forward. Yeah, no, I mean, I think all the sentinel node algorithms, at least whether people are actually doing this in practice or not, at least pay lip service to the fact that any visually abnormal lymph node should be removed. So, yeah, whether they're sentinel or otherwise. But I don't know that they go so far as to say if you see any visible abnormal nodes, you should perform a lymphadenectomy on that side. So. I agree with you. Yeah. All right. Any other questions about sentinel nodes? Yeah. Low, but some series would say as high as 4%. Yeah, with positive aortic nodes with negative pelvic nodes. So low incidence, but not zero. Yeah. All right. So your final pathology findings reveal a grade 2 endometrioid adenocarcinoma. Again, remember it's a 58-year-old. With 55% invasion, no lymphovascular space invasion, all assessed lymph nodes are negative. She recovers from surgery successfully with no complications. So what would you offer her at this point? How many people would offer no adjuvant therapy? Okay. How many people would offer pelvic radiation therapy only? Okay. How many people would offer pelvic radiation therapy with concurrent cisplatin, like chemoradiation? Anybody for vaginal brachytherapy? All right. How many vaginal brachytherapy plus additional chemotherapy? All right. So you guys are, the GOG 249 data is not convincing you? You don't believe it? It's a very heterogeneous study. I think there's when the final results are available, I think there's going to be a lot of dissenters in the U.S. based on subgroup analyses and other things. I don't know that there's going to be enough patients in each of the subgroups to really do an effective analysis. So certainly the data from GOG 249 would argue that this is a high intermediate risk patient. She meets criteria for the study, should benefit from pelvic radiation therapy. But whether or not that's whether or not when we have all the data that's available, kind of we can identify her subgroup as the one that benefited is hard to know. So vaginal brachytherapy based on the previous Portec data, yeah. All right. So she receives pelvic radiation therapy, tolerates that well without any complications. 2 years later, she presents to an outside hospital with back pain, and an MRI of her spine at that point shows a 4-centimeter mass in her left aortic lymph node space. So what would you do next? How many people would get kind of additional workup, further imaging with a PET CT scan? Still obese. Yep, still the same weight, hasn't changed. How many people would get a CT guided biopsy? All right. So for those of you with PET CT, are you more? What's your rationale for a PET CT? Yeah. Who would get a PET CT and a CT guided biopsy? What's that? Sure, unless she's got like a new retroperitoneal sarcoma. Yeah. 2 years. 2 years. Yeah. Yeah. How many people? And would anybody go right to treating her with chemotherapy? How many people would take her for surgery? No further workup? Yeah. So kind of by extension there. So if the biopsy, so let's say you go ahead and biopsy and it returns consistent with recurrent endometrial cancer. Your PET CT shows no other evidence of metastatic disease. So what would you choose as the next step? So how many people would favor resecting this mass? Pretty reasonable option. How many people would favor using directed radiation therapy to this area? It's 4 centimeters, and she's the BMI of 48. What's that? Too big. And she's symptomatic. What's that? Yeah. Some people would even argue that if you're planning to resect it, you may be able to shrink it with radiation therapy. If it's in the left aortic space, it may be near renal vessels, or you may be able to get it kind of back off the the nerves behind it if she's having back pain already from it. So I think there is some rationale even in larger patients, some in specific cases using radiation therapy. How many people are not interested in trying to resect this and would treat her with chemotherapy? There's reasonable rationale, whether that as a first step or as a kind of adjunct to again try to shrink the tumor for later. It is a grade 2 tumor, not a grade 1 tumor, so there may be more evidence there. How about hormonal therapy? Anybody favor that? And how about immunotherapy? Nobody? All right. Anybody else? Any other options? Okay. All right. So this is our case number 2. This is our 37-year-old obese gravitas 0 patient who presents with a grade 1 endometrial cancer on endometrial biopsy. No other major medical problems. She's married. She's been trying to get pregnant for the last 3 years without success. She's very interested in preservation of her fertility. And a pelvic ultrasound shows several 2 to 3 centimeter fibroids, including at least one that appears submucosal. So how many people would offer her a fertility-sparing approach? A couple of people? Yeah. And if you were let's say for those of you who would not offer a fertility-sparing approach, let's say you were forced to, which therapy would you favor for her? Megace? What's that? Miranda? Yeah. So of the people who'd favor a Mirena IUD, why would you? Yeah. Yeah. So so kind of the existing Mirena evidence is convincing enough for you? Yeah. I would say until, a couple of years ago, maybe it wasn't quite as robust, the evidence for Mirena, but it's certainly more so now. Good evidence, obviously, for the use of oral Megace. How about Lupron? Does anybody use Lupron in these patients? Yeah. I don't really have any evidence for that, but I figured I'd see if anybody would bite. What's that? You do both? Yeah. All right. So you agree to prescribe hormonal therapy with assessment every 3 months by endometrial biopsy. She has pretty minimal symptoms from the progestin therapy. She returns in 3 months, and she's got persistent grade 1 endometrial cancer on her endometrial biopsy. So, assuming that she continues to have persistent grade 1 endometrial cancer on endometrial biopsy every 3 months, how long would you continue to follow her that way before you abandon hormonal therapy? So how many people would call it at 3 months? If it's persistent at 3 months, we're not. Okay, how about 6 months? So every 3 months you're going to do an endometrial biopsy. If that continues to show grade 1 endometrial cancer every time, how long would you wait before you say we're not achieving what we want to? Okay. So we're at 6 months. Who would wait 9 months? Yeah. I mean, the trial data would say that a significant number of people, still have a response. Will still have benefit at 9 months. Yeah, and I think with there isn't randomized data to support these approaches either way, but I think that there is a fairly robust observational data in these patients to say that that's effective. And how about 12 months? I think by 12 months, most people agree that we're kind of outside the scope of what's safe. So, but waiting up to 9 months, I think, with kind of appropriate patient, appropriate monitoring, at least has some evidence to support it.
I don't know if you were there, as they lost.
Oh. Yeah.
So for me, I get nervous in 6 months. I obviously lay out the patient, but I tell her I'm very unhappy.
Yeah.
You're already out on the experimental, and there's data, which is not a lot of data, and there's failures. I talked about the failures. The difference in failures is they not.
Yeah, well, I don't argue with that at all. I do think that the consequences of missing with this are I would say that, if even at 3 months I get the endometrial biopsy back, I want to know from my pathologist who's reading that, are you seeing progestin, are you seeing progestin effect? Do we need to worry that potentially she's not taking therapy if there's really no effect? I think in some ways there is some benefit to the Mirena IUD there, and that it's not necessarily reliant on her taking the Megace or taking it at inconsistently. So, all right. So moving on to cervical cancer. Yeah. What dose of Megace? Well, yeah. What? Yeah. I think that's generally where most people start, and divide what. I usually recommend people take it twice a day, but because so they're taking 80 BID. Or changing the therapy. I think it depends somewhat on. So assuming that you feel like she's taking it reliably, has tolerable side effects from it, and it appears like there's some progestin, maybe she, it appears there's some effect, just not resolution yet of the cancer on her endometrial biopsy. It may be beneficial to increase the dose. Probably that's not necessary. Probably if there's an effect there at 160, you can continue that. You just may need more time. What's that? Yeah, and I guess I'm, the process in the United States of getting a gastric bypass surgery usually takes more than a year from when the patient presents for it. They usually require at least 6 to 12 months of weight loss program, counseling, a whole bunch of hoops people need to jump through before they'll actually take them to surgery. So, on one hand, there's no problem kind of getting that process started sooner, but it usually isn't something where you can say, in the next 3 months you'll have this procedure. 3 months after that, you'll probably be able to, have lost a significant amount of weight, and we may be able to start to see a change in your risk factor profile for this. You're thinking more that it's, 18 months, 24 months off before you may start to see that sort of benefit. Yeah, no, I mean, I think with the exception of a patient who has a very abnormally shaped uterine cavity that you know about, you should get a pretty representative sample of endometrial biopsy. And I really feel like, if the goal is to try to get pregnant in a, some interval of time before, this starts to happen again, I usually do recommend, after that first negative biopsy that they proceed with, trying to get pregnant. After one normal one, yep. Absolutely. Yeah. No, I that would speed the process along significantly, usually. Yeah, I mean, majority of these patients have other risk factors than just, the same thing that predisposed them to endometrial cancer, frequently was a, factor in their, in infertility as well, so. You mean a second child? Yeah. I think that that's kind of has to be a case-by-case basis. I think in a patient who's demonstrated that she's reliable and will be monitored effectively, then, I think that, at least for me, I would feel kind of uncomfortable saying that we're not going to give her the choice of that. All right. Okay, cervical cancer. 34-year-old gravida 2 woman presents with vaginal bleeding, is found to have a 4.0 centimeter ectocervical mass. Cervical biopsy shows a grade 2 squamous cell carcinoma. An exam under anesthesia is performed that does not show extension to the upper vagina or palpable extension to the perimetria. Would any of you request any further workup before deciding on a definitive management plan? So how many say, no, based on this information, I'm ready to proceed with my plan? All right. How many people would check a CT scan? Okay. And how many people would kind of favor getting a PET CT scan? In terms of deciding between the two, for the people who favored CT scan, why would you favor that over a PET CT? What's that? Yeah. I think certainly for GYN cancer, we have more data looking at utility in cervical cancer than we do in other GYN cancers. But I think it's fair to say that we don't have definitive data, really randomized data for any imaging study. Yeah. Mm-hmm. And then for people who favor PET CT scan, what would? Yeah. Yeah, I mean, does the fact that her she has a 4 centimeter tumor change your rationale? Let's say she had a 3 centimeter tumor. You'd proceed the same way. Yeah. What if she had a 6 centimeter tumor? Okay. All right. So, okay. So let's say you get your imaging. It does not reveal any metastatic disease. What would you recommend for treatment? So how many people would proceed with a radical abdominal hysterectomy and staging? Okay. Sure. Let's say kind of you feel that her single greatest dimension of the tumor in her cervix is going to be 4 centimeters. How many people would do this laparoscopically? So laparoscopic radical hysterectomy and staging. If you will, you're braver than me. How about robotically? I will say the robotic technology makes minimally invasive radical hysterectomy significantly easier than laparoscopic radical hysterectomy. That being said, 4-centimeter tumor is kind of, still frequently difficult to do minimally invasively. How many people would favor pelvic radiation therapy alone? How about chemoradiation? Yeah. So most people would favor surgery. I think there's a reasonable rationale in this patient for primary chemoradiation. By Sudless criteria, she's got a reasonable chance of having disease that's going to require adjuvant radiation. So, I think depending on what side of the fence you fall in terms of, the possibility to avoid radiation therapy is an important consideration. But so you go ahead and you proceed with radical hysterectomy, and the first thing you do is expose your right pelvic lymph nodes, and you see a 3-centimeter lymph node there at the iliac bifurcation. And so you remove it. This node's confirmed to be a squamous cell carcinoma by frozen section. So what do you do next? So how many people proceed and complete the rad hyst? Okay. How many people abandon the radical hysterectomy and say, you're going to need radiation therapy anyway, and so, okay. How many people get a little more information, complete the lymph node dissection, and then don't do the, abandon the hysterectomy? Okay. And then how many people don't do the pelvic part, but complete an aortic node dissection and abandon the radical hysterectomy for radiation therapy? All right. So, so for those of you who would go ahead and complete the radical hysterectomy, what would be your rationale for that? What's that? Huh? Yep. Mm-hmm. Yeah. I think I would say this issue has a wide range of opinions about what people feel comfortable with. That's very much informed by their own anecdotal experience, because it's, I think it's difficult, this population of patients in practice is more heterogeneous than it seems to be in the published trial data. And I do think that the rationale for avoiding radical hysterectomy is very different when you have parametrial involvement than when you have lymph node involvement. You're not necessarily worried as much if the parametria are clear that you're hiding disease in the sidewall that's not going to be accessible to radiation or whatnot. Certainly you're still left with the issue of having, a significant pelvic disease as well as, likely other metastatic disease that's may or may not be managed with radiation therapy and is going to pose a worse prognosis for the patient. I've had more than one patient in this situation that we decided not to do a hysterectomy, never, be kind of very unhappy about the decision that I made to leave her tumor in place afterward, and subsequent kind of complications from the radiation therapy that she felt could have been avoided if she got a lower radiation dose. So, I do think there certainly the available evidence in this situation for most patients would support not proceeding with the radical hysterectomy, but certainly anecdotally there are patients that I can point at that probably would have been the right decision.
Much better for them to control the loss distribution side, and the dose distribution will be much worse.
If the uterus is removed.
If it is removed.
Correct,
If
correct.
it's not removed, it's much better for the planning. And for the application of the brachytherapy itself, if you lift the cervix in place, you can arrange the brachytherapy in a much better way than if you did an extended radical expansion and you remove the big part of the vagina.
I think no doubt about it, it is much easier for them to focus the radiation dose with a combination of external beam and brachytherapy if the uterus and cervix is in place. Like no ifs, ands, or buts about it. So. Mm-hmm. Yeah. Yeah. Sure. And I think that would be, it seems like the majority of our patients, even who have a completely obscured os at the start of radiation therapy, by the time they finish their external pelvic radiation, most of them have at least a channel that you can see, or kind of under anesthesia identify to place a brachytherapy apparatus or a sleeve or something. Yeah. 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 All right. Any other questions? For this patient? What's that? I would complete the lymph node dissection but leave the uterus in place. Yeah. I would, because but again, it's anecdotal. I've had a handful of cervical patients with, either occultly positive aortic lymph nodes or aortic lymph node recurrences that a short time after therapy that clearly were there, must have been there at the time of initial surgery, and low enough that I would have included them in my aortic node dissection. So yeah, it's anecdotal, but